Can we start?
Yes, sir. Just 30 seconds. Done, sir.
We can start?
Should I start?
Yes, sir. You can.
Yeah, please go ahead, Gajit.
Good morning, everyone. Today I'll be discussing about the role of steroids in the ICU. As we all know, steroids are important for the normal homeostasis in the human body. So the steroids, which are molecules produced in the adrenal cortex, the gonads, and the placenta, which have a variety of staggering roles. Is my voice clear or is it echoing, sir?
It's echoing. Have
Am
you
I
logged in
audible,
with
sir?
two systems? No, you're audible. Have you logged in with two systems?
No, sir. Only one system.
Okay, go ahead.
1 second, sir. So steroids are the molecules which are produced in the 1 second, sir. I'm not able to. I'm hearing my own voice.
Your voice is okay for us, so please continue.
You have accidentally exited the presentation. You have to reshare it.
Uh, I'll continue with this one, sir. Steroids are.
No, your presentation is. You have closed
We
the
can't see
presentation.
your PPT. You can't see
You
the
have to
presentation.
reshare it, Kadir.
Sorry, sir.
Presentation, you exited it. So you have to reshare the presentation.
Okay, sir. 1 second, sir. So, am I audible, sir?
Yes, continue.
Steroids are the molecules which are produced in the adrenal cortex, the gonads, and the placenta. They have various role in the human physiology to maintain the normal homeostasis. The steroid functions can be divided into glucocorticoids, mineralocorticoids, and the androgens. So, mineralocorticoids mainly it helps in the salt and water retention. Glucocorticoids are useful in the maintaining the homeostasis like normal hemodynamics and all. And medulla which secretes the epinephrine, which is the most important vasopressors which are produced in the human body. So as we all know, steroids are the double-edged weapons. When we used in cases of infection or sepsis, it can worsen the outcome of the patients. And in cases where there is adrenal insufficiency, when the patient requires the supplementation of the hormones, steroids, specifically the glucocorticoids, they will be useful in patients. And we will be discussing about the use of these steroids in conditions like sepsis, ARDS, post-extubation stridor to prevent post-extubation stridor, anaphylaxis, trauma, spinal cord injury, and few other sections I'll be discussing with. As cortisol is a primary glucocorticoid, its production is released by the ACTH of the anterior pituitary. Aldosterone is a major mineralocorticoid, which secretion is controlled by the RAS system, which is key regulator for the blood volume and the systemic vascular resistance. We all know that in cases of the patients who are hospitalized, they will be having dysregulated inflammatory response, which will have a deficiency of the steroids which are released. And the Critical Care Society, Task Force Society of Critical Care Medicine, and the European Society of Intensive Care Medicine introduced the term critical illness-related corticosteroid insufficiency, as you all know by like CIRSE, which is more common in the ICU patients. So during illness, the production of this ACTH is low, while cortisol levels tend to be normal or usually high, and the diurnal variation of this cortisol is also lost. More than 90% of cortisol will be bound to the binding globulin, which tends to fall during the critical illness. As we all know, like sepsis or any other illness is relative protein deficiency or albumin deficiency. So the binding of these cortisols will be hampered, and only 5 to 10% of this free cortisol will be available, and that will be biologically active. So SERSI, as I told, is a state of systemic inflammation which is associated by dysregulation of the hypothalamic axis, pituitary adrenal axis, which alters the cortisol metabolism and the release of the steroids in the body. The task force updated the guidelines in 2017, recommendations for diagnosis of SERSI and management of various clinical conditions. As when the corticosteroids are released from the body, they bind to the receptors in the cytoplasm. They enter into the nucleus, activates the receptor complex, binds to the DNA, and this complex alters the proteins which are produced by the nucleus, changing the function of cell in number of ways, and they downregulate the release of inflammatory mediators in cases of inflammatory storm or in cases of sepsis. These inflammatory mediators will be downregulated by this action of the steroids. So during severe stress, the expression and activity of these enzymes are reduced, leading to decreased clearance of cortisol. The incidence of SIRSI varies from 20 to 60% in patients of septic shock and 21 to 75% patients in HIV infections who are critically ill, and also in 15 to 50% of patients with traumatic brain injury. The most common clinical features when we experience patients having SIRSI will be hemodynamic instability despite adequate fluid resuscitation, fever and inflammation without an obvious source of infection that does not respond to the empirical antibiotic therapy. So non-specific signs can also be present like altered mental status, gastrointestinal symptoms like hypoglycemia, eosinophilia, hyponatremia, and hyperkalemia. All these features can be because of the cortisol deficiency. Hyponatremia and hyperkalemia are less common than in patients with primary adrenal insufficiency, in whom they may be more prominent. So patients who are having adrenal insufficiency, they may have hyponatremia and hyperkalemia. Many conditions can be associated with SIRSI that can be sepsis, septic shock, ARDS, major trauma, severe bacterial pneumonia, bacterial meningitis, non-septic shock states like cardiopulmonary bypass, post-cardiac arrest, cardiogenic shock, and burns. When administering a patients with steroids, we need to know the relative potency of each and every steroid so that the changeover from one dose to other dose or oral to IV form will be helpful, and adequate dosing can be given. As we all know, the equal potency of hydrocortisone is glucocorticoid, and mineralocorticoid potency is 1 and 1, and the equivalent dose is 100. So whenever we are using other methylprednisolone, 20 mg of methylprednisolone will be equivalent to the 100 mg of hydrocortisone. So these conversions is important for understanding the changing of one group of steroid to other group of steroid, like a glucocorticoid to a mineralocorticoid, or when patient is being shifted from a IV solumedrol methylprednisolone to IV prednisolone, we need to know these conversions. The most potent, as we all know, is dexamethasone, and we all should understand that the conversion potency of these medications has to be understood. We know that sepsis is a state of inflammatory response, which is a dysregulated human response to the of the body. The steroids have been educated in the management of septic shock based on the hypothesis, which we all know, of relative adrenal insufficiency. Patients usually in stressful conditions, they will have increase in the cortisol production, but because of this adrenal insufficiency, the body cannot match up with this stressful response, and cortisol cannot be released, and that the body lands up in a state of relative adrenal insufficiency. These assessment of adrenal reserve prior to the administration of steroids is not routinely advocated because of the unreliability of the ACTH test to predict responders versus non-responders. So whenever we want to know whether the patient is responding to a steroids or not, previously based on the different trials, adrenal trial, they have looked for ACTH stimulation test, where they have seen patients who, after administration of cosyntropin 250 microgram, they have monitored the levels of cortisol at 30 minutes and 60 minutes, and where in patients who have increase in the levels of cortisol were considered as responders, and in whose patients where the cortisol levels cannot be increased after stimulation were considered as non-responders, and those were the group of the patients who were administered with cortisol, and they have seen the benefit in terms of shock reversal. So in sepsis, there were many trials which were conducted. The major trials were adrenal trial, which have shown shock reversal in patients who have been administered with cortisol. There were few trials in the early in 1976, which were started with the administration of methylprednisolone, which were given as a higher dose of almost 30 mg per kg was given versus a placebo. They found that the beneficial effect was in terms of shock reversal. The major randomized control trial, which we can see, is Annan et al., which came in 2022. It was a randomized controlled trial from the French group. They see again based on the ACTH responders and non-responders, and steroids were administered. The only flip side was they were not the only trial which have shown was mortality was slightly reduced, but shock mortality was decreased and shock reversal was early. One more trial is approaches trial, which have used activated protein C along with hydrocortisone. Again, they have shown this is the only trial which have shown mortality benefit. All other trials have shown only the benefit of administering steroid has shown only shock reversal. The other negative trials which have shown no benefit is like Cronin et al., which was done a meta-analysis trial, and Coits, it was published in 2010. They all showed that there was no benefit. So different trials have showed few were the positive trials which have showed a mortality, like only approaches have shown mortality benefit. Others have shown only early shock reversal. The other trials have not showed any survival benefit. So it was difficult for us to conclude, say what exactly has to be done. But in patients who are having septic shock, administration of steroids have proven to be benefit in terms of shock reversal. But steroids should not be used in patients who are having sepsis without shock. They showed no benefit. So as I told, Schumer trial was conducted in 1976 that included almost 172 number of patients, placebo versus saline. Increased mortality in the placebo group, methylprednisolone group had a benefit. And another et al. Trial which showed a benefit in terms of shock reversal. Cronin et al. 1995 meta-analysis was done by a Canadian. They showed increased mortality in septic shock. Coits trial in 2010 showed no survival benefit. So these were the differences where a few trials showed positive and few trials showed negative benefit. Again, Journey et al. Trial, which showed basis of cortisol administration based on the ACTH responders versus non-responders because of the basis of relative adrenal insufficiency. Corticus was a large trial which was conducted in 2008 with administration of hydrocortisone. It showed improvement in survival, but no improvement in survival, but there was a quick shock reversal. As I told, this was a major trial. They administered 50 mg of IV steroid in 6 hours. Shock reversal was there. And they in this term, response to cosyntropin stimulation test does not seem to matter because it was difficult to be conducted in all those patients, cosyntropin test. In 2016, Hypress trial with the 380 patients were done. They found that 200 mg per day of hydrocortisone was given over 5 days does not prevent the progression. At preemptive administration of patient in sepsis, they could not help in preventing patient landing up in septic shock, indicating that steroid should not be used for patient with sepsis who are not in refractory shock. As I told about this adrenal trial, the adjunctive corticosteroid treatment critically ill patients with septic shock in 3,800 patients. The most advantage of this study was it included large, the extent of this study was clinically significant based on the study which showed large number of patients. There was shock reversal and also clinically significant ventilator mechanical ventilation free days was there. So this has shown a positive benefit. The flip side of these effects were there was no secondary outcomes, no difference in the secondary outcomes. The adverse effects were more in the hydrocortisone group, which are hyperglycemia, increase in the sodium, myopathy, and also patients may have bowel ischemia also with giving administration of steroids. As I told, the other trial was activated protein C and corticosteroid for septic shock. It was done in 1241 patients, used combined use of hydrocortisone 200 mg in divided doses, 50 mg IV for 6 hours and fluorocortisone 50 microgram enterally for 7 days. At 90 days, fewer patients in the steroid group had died, shock reversal was faster, and the steroid regimen was found to be safe. Hyperglycemia was the most common adverse effect which was seen. At 180 days, the survival benefit remained the same. In 2019, a Cochrane meta-analysis found that the corticosteroid therapy probably reduces the hospital mortality by about 9% and results in larger reduction in the length of the stay in the intensive care unit by about 1 day and in hospital by about 1.5 days. Corticosteroid therapy was associated with, again, the side effects like hyperglycemia, hypernatremia, muscle weakness was there, and there was no increased risk of super infection. There was little difference in GI bleed, neuropsychiatric symptoms, stroke, or any other cardiac events. In 2020, based on artificial intelligence, Piracci et al. Entered the data from about 2,500 patients from septic shock clinical trials into a program to attempt more precisely determine who should receive steroids based on the multiple patient variables. They found that the strategies to treat all patients with steroids or to treat no one were associated with a worse outcome. In contrast, an individual estimation-based treatment strategy always yielded a positive net benefit. So we should understand the individualization of the treatment in patients who are having refractory shock have shown to be benefit like early shock reversal. The mortality benefit was not seen in many of the trials except for the approaches trial. In the other group of patients where we see for the use of steroids is ARDS. We all know that ARDS is a heterogeneous clinical condition with multifactorial etiologies based on like extra pulmonary and pulmonary causes of ARDS. Steroid for ARDS management are like a debate. In recent RCTs like DEXA ARDS, which was conducted in Spanish, it was a Spanish trial which was conducted from 17 ICUs. Use of early dexamethasone. Early means first 5 days or first 7 days. Use in moderate severe ARDS. How they defined the severe ARDS was the PF ratios less than 200 and FiO2 requirement of 0.5 and PEEP of more than 10 for more than 24 hours were considered as severe ARDS patients. They showed the benefit in terms of ventilator-free days, and the confidence interval was 2.5 to 7.03. This was statistically significant. The other trial which was conducted was Meduri et al. Trial in 2007. It was a double-blinded placebo-controlled trial in 91 patients with severe ARDS within 72 hours. 66% patient had sepsis. They were randomized in 2:1 group receiving methylprednisolone infusion of 1 mg per kg per day versus placebo. The dose was tapered and slowly weaned off over a period of 21 days. They did frequent surveillance based on bronchoscopy to rule out any other secondary infections, and they avoided neuromuscular blockade so as not to increase the chances of neuromuscular weakness as a side effect of steroids. The primary outcome was a reduction in the lung injury score or a successful distribution by day 7, both of which were achieved. So this is a positive trial which has showed the use of methylprednisolone beneficial in cases of patients who were given early steroids as early as like less than 72 hours. There were also significant reduction in the duration of mechanical ventilation free days, length of stay in the ICU, and the overall mortality. The 2017 guidelines gave a weak recommendation for the use of methylprednisolone 1 mg per kg per day. The trade-off was hyperglycemia, and there was no increased risk of neuromuscular weakness, GI bleed, or nosocomial infections if these steroids were given as a dose of 1 mg per kg per day. As I told, the positive trials were 2 trials, like dexamethasone in ARDS, which was a recent trial in 2020. The other trial is early trial in methylprednisolone, Meduri et al., which was done in 2007. Showed the benefit in terms of ventilator-free days, reduction, increase in the PF ratios, and length of hospital stay. The negative trial, which was published in NEGM in 2006, was a major randomized control trial. They used a higher dose of methylprednisolone. So the use of higher dose of methylprednisolone and in later days of disease showed worsening of the clinical outcome and increase in the length of the stay. So use of corticosteroids in acute lung injury and ARDS showed the meta-analysis showed a positive trial. So in early stages, if you use cost benefit, but after 14 days, if methylprednisolone was given in as ARDS patient, they showed a increase in the mortality. The infections which the other area of where we use steroids is like infections. As we all know, the infections, it's an inflammatory condition. The steroids which are bind to the glucocorticoid receptor cause the inhibition of the pro-inflammatory genes by binding to the nuclear factor kappa beta in the leukocytes, thereby decreasing the pro-inflammatory cytokines. So in cases of bacterial meningitis, the dose of like steroids were given. Dexamethasone were usually considered at a dose of 8 mg per kg, 8 mg IV TID. These did not improve the infection rate, but they decrease the sequelae of inflammation of the meninges, like by decreasing the patients had lesser hearing loss and all. So when an immunocompromised patient with CNS disease or new onset seizures were like having a suspicion of bacterial meningitis was there. If there were no suspicion, then blood cultures and lumbar puncture was done. Dexamethasone was empirically started along with antimicrobial therapy. CSF was done, which was if it was positive for any organisms, we continued the steroid. And if it was any like negative, CSF findings are not suggestive of any meningitis, we were considering the alternate diagnosis. If the blood cultures are positive, dexamethasone plus empirical antimicrobial therapy was given. We performed CT head if there was any contraindication for lumbar puncture. If lumbar puncture was positive, we continued the antimicrobial therapy along with the steroid. Dexamethasone at a dose of 0.15 mg per kg every 6 hours should be given shortly before or at the same time of antimicrobial agents. As I told, the benefit was in terms of preventing the sequelae of the meningitis, like hearing loss and all. Dexamethasone should not be given to patients who have already received antimicrobial therapy because the outcome may not be seen in those patients. The other area where we usually follow administration of steroids is pre-extubation. The incidence of post-extubation stridor varies in the ICU based on like the patients who are high-risk patients. I will be discussing who are all the high-risk patients. The incidence varies from 1.5 to 26%. The ATS Society recommends methylprednisolone 40 mg IV 4 hours before extubation in patients who have failed a cuff leak test. We usually like check for a cuff leak, which is approximately we should have 110 ml. If the patients who are having less than that, so there are very high chances that the patients may be landing up in post-extubation stridor. So the high-risk patient group, which are more prone for post-extubation stridor, are patients who have difficult airway, difficulty intubation, like multiple manipulations or longer time to intubate, or polytrauma patients. So in these patients, if you are given methylprednisolone 4 hours prior to extubation, they have shown lesser incidence of post-extubation stridor. The other area where we use in ICU is acute exacerbation of asthma patients who present to ED where they have acute exacerbation. The dose of methylprednisolone 6, and when they come to ICU, the dose which we use is 60 to 80 mg IV BD or QID for patients who are admitted to the intensive care unit, while a lower dose 40 to 60 mg IV OD is considered patients who are admitted to the hospital but does not require the intensive care. A massive initial dose of 500 mg methylprednisolone is no more effective than large initial dose of 125 mg. So, like bolus doses or loading dose of methylprednisolone has not proven any benefit in case of acute exacerbation of asthma. Again, in management of severe COPD, the step-up approach where they first initially use SABA, then SAMA, and then inhalational steroids. If the patient is having severe COPD where severe spasm is there, in those patients, like methylprednisolone, again 60 mg to 125 mg, repeat every 6 to 12 hours till we get benefit of the relieving of spasm or in terms of improvement in the ventilatory graphics. This was supported by the gold guidelines for the use of prednisolone 40 mg once daily for the majority of COPD exacerbations. As we all know, the benefit of steroids in spinal shock and TBI. TBI, we all know that there is no role of steroids in traumatic brain injury. In spinal shock also, we have seen the major landmark trial was NASIS 3, which showed if we were given early, less than 3 hours, there was again no improvement in terms of either recovery in terms of motor power and all was not there. Mortality and morbidity was almost the same. As these guidelines show that NASIS 3 shows that there is no benefit of steroids in traumatic spinal cord injury. There are society guidelines that American Association of Neurological Surgeons does not recommend the corticosteroids in traumatic spinal cord injury. Canadian Association of Emergency Physicians, the treatment option, it is one of the treatment option, but cannot be the standard of care of treatment. In Consortium of Spinal Cord Medicine, they showed there is no clinical evidence of administration of steroids and the use can be avoided. And NASIS 3, they have like two groups were divided, less than 3 hours. They administered the methylprednisolone at 24 hours and then 48 hours. And again, the 3 to 8 hours, they showed even in these two groups, whether it is administered early or in the later part of administration, there was no benefit of the steroid. So we all know that this, like we usually don't follow, but few of the surgeons, they usually keen in administering the glucose if they present to us in a multiple trauma patients and all, but there is no role of steroids in as per the guidelines. These are Cochrane database of traumatic brain injury. They showed largest trial which included 20 trials for the meta-analysis, largest study which included 20 trials. The routine use is not suggested and there is no beneficial outcome of the patients if we administer steroids in traumatic brain injury. In polytrauma patient, it was the last one study was done. There's only one study, hypolite study. It is a meta-analysis which included many randomized controlled trials. The beneficial effect in reducing the duration of mechanical ventilation in hospital-acquired pneumonia was seen in patients who were administered steroids in polytrauma patients. But as we all know, that this is only one study which has come, which has used steroids in polytrauma patients. But overall, the benefit was in terms of mechanical ventilation free days and the duration of the incidence of hospital acquired pneumonia was less, but only one study was conducted. So based on that single study, recommendation cannot be made, or we cannot use steroids in polytrauma patients. As we all know, even in potentially like organ donor brain dead patients, they will have relative adrenal, the disruption of hypothalamo adrenal pituitary axis will be there. They'll be having dysregulation of this autonomic response. Methylprednisolone 1 gram was given, 15 mg per kg IV was given, followed by an infusion of 100 mg per hour was considered in few patients, because to prevent the adrenal insufficiency in patients having because of the loss of hypothalamo pituitary adrenal axis. So we have to administer other hormonal resuscitation should also be done along with the steroids. Anaphylaxis, we all know the major role of steroids in anaphylaxis is not exactly in preventing the immediate reaction. It can be used to prevent the biphasic response, which will be seen after 48 hours. So the role of steroid after 48 hours has no role. We cannot be administered in patients with anaphylaxis. Early in the onset, that's a routine practice we do, but there is no evidence to conclude that there is any role of steroids in anaphylaxis. So I'll try to end my lecture by discussing few of the points. Steroids use have no mortality benefit in septic shock. However, it helps in early shock reversal. Steroids should not be used in patients with sepsis without shock. Only patients who are having shock, which is refractory, and if the shock is for more than the inclusion criteria for many of the trials for the shock with vasopressor maintaining for 4 hours, we have to start with a dose of hydrocortisone 50 mg or a 200 mg per day bolus. Many trials have been shown the beneficial effect of early shock reversal, but mortality benefit was not there. Steroid used early in ARDS has a possible outcome. As I told, early like within 48 to 72 hours, late more than after 14 days of severe ARDS, there is no role of steroids, and they have seen there is mortality, like increase in the mortality and increase in the ventilation days. So the benefit was in terms of ventilator-free days if it was being given in the early days, as DEXA, which was a Spanish trial, which showed early was like they started with a dose of 20 mg per kg for the first 5 days, then later on reduced to 10 mg per kg. They have shown if dexamethasone was given at a dose, they have a beneficial effect in terms of ventilator-free days and increase in the PF ratios and decrease in the length of ICU stay and overall hospital stay also. Steroid is beneficial in high-risk patients for preventing stridor. As I told, the high-risk patients are those who have difficulty in intubation, multiple attempts, and all, and polytrauma patients. They have, when administered 4 hours prior to extubation, they have been shown to benefit decrease in the incidence of post-extubation stridor. But the routine use of steroids prior to extubation is not recommended. And in cases of steroids in traumatic spinal cord injury, the American Association of Neurological Surgeons does not recommend the use. And even our NACIS-3 trial did not show any outcome in terms of recovery for the patients who have been given steroids in traumatic spinal cord injury. Thank you.
Yeah. Thank you, Gadir, for taking us through the various indications for the use of steroids in a critically ill subset of population. I think steroids, among a lot of other drugs, are one subset of drugs which have been tried in multiple scenarios, and there are certain scenarios where it has shown some benefit, and there are some scenarios where probably it's better to avoid it. And in certain scenarios, it has shown a different kind of response. For example, in COVID pneumonia, there was a definitive benefit of use of steroids in patients with COVID pneumonia related ARDS, whereas in H1N1 related ARDS, there was a contrary. In fact, there was increased mortality in patients with swine flu related ARDS. So I think apart from the pathophysiology, sometimes probably it also matters what triggers the pathophysiology. I think steroids, as Kadir said, one also needs to identify what type of steroids have been studied. Now, there is a common tendency for interchanging steroids. But if we are doing it, then one needs to be very clear about the dose equivalence and conversions so that we do not underdose or overdose patients with steroids. Apart from the indications which have been discussed, the other indications where steroids have been have a big role is in transplant medicine, especially immunosuppression post transplant, and connective tissue disorders, especially patients who come with exacerbations or worsening of connective tissue. I think these are other two conditions where there is a definitive role of steroids in intensive care. Thank you. Srinivas.
Excellent review. Most of the points have been covered. If anybody has any queries or comments on the topic presented, please do post them on the group from where you got the link from, and we'll answer them. So please do join us again next week for another interesting session on HICS, and subscribe to our YouTube channel. Thank you very much. Have a good day. Bye.
Thank you, sir. Thank you so much.
Thank you.